Let's jump right into this explainer on high-yield pulmonary decision logic for Step 2 CK. We're focusing strictly on airway damage, chronic cough, and hemoptysis triage. We'll break down the anatomic splits for productive coughs, the pathophysiology of bronchiectasis, the diagnostic criteria for ABPA, how to localize recurrent pneumonias, and the management of diffuse alveolar hemorrhage.
So, you have a patient with a subacute or chronic cough, meaning it's lasted beyond 3 weeks and their physical exam is completely normal. Your next best step is actually an empiric watch and wait approach before you even think about ordering imaging. You want to systematically target the most common culprits first. Stop any ACE inhibitors they might be taking, trial an oral first-generation H1 blocker for upper airway cough syndrome, do pulmonary function tests if you suspect asthma, and start an empiric proton pump inhibitor for GERD. You only proceed to a chest X-ray to look for parenchymal disease if there's zero improvement after trying these interventions.
But you can't always just watch and wait. There are specific clinical red flags that mandate bypassing that empiric approach so you can immediately initiate a targeted workup. For example, if you hear a paroxysmal cough, suspect pertussis. If there's a sudden choking onset, think foreign body aspiration. Any known tuberculosis risk, severe immunodeficiency, failure to thrive, hemoptysis, or focal exam findings like a unilateral wheeze, all of those strictly require an immediate chest X-ray or targeted diagnostic testing.
When you're categorizing a chronic productive cough, you need to establish right away whether it has an upper or lower airway origin. Upper airway etiologies like chronic sinusitis or postnasal drip usually present with that distinct sensation of liquid dripping down the back of the throat. Lower airway parenchymal disorders, which include chronic bronchitis, non-asthmatic eosinophilic bronchitis, and bronchiectasis, are different. They present with actual sputum production, purulence, and potentially hemoptyses. Diffuse alveolar hemorrhage is another lower respiratory tract process, but it presents with dyspnea, hypoxemia, and anemia, and frank hemoptyses might actually be absent.
Let's look closer at bronchiectasis. The pathogenesis here is basically a vicious cycle. It starts with an initial airway insult, like a severe infection or a toxic inhalation. But that's combined with impaired mucociliary clearance from something like mucostosis or an underlying immunodeficiency. Because the lungs fail to clear that initial insult, it leads to chronic bacterial overgrowth and intense inflammation. This permanently dilates and thickens the airways. Clinically, this gives you daily production of voluminous, thick sputum and acute exacerbations that feature mucopurulent sputum and frank hemoptysis.
To confirm that diagnosis, you need a high-resolution CT scan of the chest. The absolute hallmark finding is a lack of bronchial tapering, meaning the airways remain dilated way out into the peripheral one-third of the lung. You'll also see the signet ring sign, where a dilated airway is visibly larger than its accompanying pulmonary artery, and the tram track sign, which represents severe parallel airway wall thickening. An obstructive PFT pattern and crackles or wheezing on the exam give you corroborating clinical evidence. Treatment requires aggressive airway clearance, chest physiotherapy, mucolytics, vaccination, and culture-guided antibiotics for exacerbations.
Determining the underlying cause of bronchiectasis comes down to a crucial exam-facing distinction. Is the disease focal or diffuse? Focal bronchiectasis is isolated to just one area. That indicates an upstream airway obstruction, like an endobronchial tumor or a foreign body, and it absolutely mandates a bronchoscopy for airway inspection and intervention. Diffuse bronchiectasis involves multiple lobes. That points toward a systemic or airway clearance disease, like cystic fibrosis, primary ciliary dyskinesia, severe immunodeficiency, allergic bronchopulmonary aspergillosis, or autoimmune conditions like Sjogren's syndrome and rheumatoid arthritis. For diffuse disease, you need a full systemic laboratory workup.
This logic applies directly to recurrent pneumonia as well. Geographic localization dictates your diagnostic next step. If the pneumonia keeps recurring in the exact same lung lobe, you're looking at a localized anatomic problem, which raises suspicion for a bronchial obstruction from a tumor or a foreign body. But if the pneumonia recurs in different lung lobes over time, that suggests a systemic predisposition. You need to evaluate for recurrent aspiration, immunodeficiencies, or sinopulmonary diseases like cystic fibrosis and primary ciliary dyskinesia. Now let's transition to allergic bronchopulmonary aspergillosis, or ABPA. This is a hypersensitivity complication that occurs specifically in patients who already have impaired airway clearance, usually from underlying asthma or cystic fibrosis. The pathogenesis happens in 3 steps. First, the airways become colonized with Aspergillus fungal spores. Second, the immune system mounts a Th2-based allergic sensitization. Third, this triggers destructive allergic inflammation. Remember, the clinical damage here is driven by this intense immune response, not by an invasive fungal infection.
The classic presentation of ABPA is a patient with difficult-to-control asthma and really thick sputum. The major diagnostic clue is an unexplained decline in lung function that simply fails to improve despite an appropriate course of antibiotics. On imaging, you might see fleeting infiltrates, central bronchiectasis, or bronchial mucoid impaction. To confirm ABPA, you need evidence of Aspergillus sensitization. That means a total serum IgE generally soaring above 1,000 IU per milliliter, a positive Aspergillus skin test or specific IgE, and supportive evidence like eosinophilia or Aspergillus IgG.
Treatment for ABPA targets the dual nature of the disease. Your next best step in management is initiating systemic glucocorticoids to rapidly suppress that destructive allergic inflammation. But you have to pair that with an antifungal drug, typically voriconazole, to decrease the overall fungal spore burden and remove the inciting antigen. Finally, you optimize their underlying asthma therapy to keep their airways as clear as possible.
Let's conclude with some definitive triage rules for focal obstructions and pulmonary bleeding. Sudden onset respiratory distress in a toddler with a choking history and a focal unilateral wheeze is foreign body aspiration until proven otherwise. A chest X-ray might show hyperinflation on the affected side, but at least 30% of these radiographs are completely normal if the object is radiolucent. A normal X-ray does not rule out the diagnosis, and persistent clinical suspicion strictly requires immediate bronchoscopy. If airway damage leads to massive hemoptysis, immediately protect the airway, position the patient with the bleeding lung down, and utilize CT angiography or bronchoscopy. Finally, for diffuse alveolar hemorrhage, which presents with dyspnea, hypoxemia, anemia, diffuse ground glass opacities, and progressively bloodier lavage, you must evaluate for systemic etiologies like ANCA vasculitis, SLE, antiphospholipid antibodies, mitral stenosis, cocaine use, or anticoagulation.